Okay. Okay. So good afternoon, everybody. I really am honored to be here today. I did a similar presentation last year, and I thoroughly enjoyed the interaction and I would say the fellowship. And so I'm really looking forward to being with you again. My name is Horace Delisser. I am a pulmonary and critical care specialist at the University of Pennsylvania. I do research, some of which is cancer-related. I do medical education, focused on cultural competency and medical ethics. And I also do clinical care, both outpatient pulmonary medicine as well as inpatient critical care. And in my clinical encounters, both as an outpatient, in terms of outpatient physicians as well, patients as well as inpatients, issues of cancer and end of life come up quite often. And what I would like to do today is to share with you some thoughts and some ideas, some suggestions that I have found in my experience are helpful to patients as they make this journey, this cancer journey. And you may be in a position where you've just been told you have a diagnosis, and it's just a new experience for you. Or you may be in a position where you've had surgery, you've had some treatment, and you're now waiting to see what will happen. Or maybe it's a loved one who has cancer. I think regardless, the things I'm going to share with you today I think will be helpful to you. And what I'm going to do is offer 7 suggestions for making that journey, that cancer journey, in a successful way. My first suggestion is to forgive yourself. Second, inform and educate yourself. Third, assemble a network of support. 5, reestablish or reaffirm your important relationships. 5, become comfortable with palliative and hospice care. 6, take control of your future. And then 7, leave something behind. Give something back. So we're going to take a few moments to go through each of those 7 suggestions. At the end of all this, I'm going to get some suggestions from you. Because I would hope that in the time that we have, this is not just me speaking and lecturing you, but we also turn it into a dialogue where you're also sharing with me as well. So let's begin with forgive yourself. I start here because many lung cancers, in fact, the majority of lung cancers are smoking related. And in my experience, I find that many people, when they have a lung cancer diagnosis and look back on it, have a sense of guilt, blame, shame around that diagnosis. Again, those are common emotions, those are common reactions. Again, often because it's related to things that I did. That guilt, that shame, that anger at oneself can oftentimes be very debilitating and very corrosive on your spirit and on your soul. And so, although these emotions are normal, I encourage you not to dwell on them. Forgive yourself and look forward. And in many ways, part of that process of forgiving oneself involves a number of the suggestions that I'm going to make subsequently. But I think the words of this person is very appropriate. When guilt rears its ugly head, confront it. discuss it, and let it go. The past is over. It is time to ask, what can we do right? Not what we did wrong. Not what did we do wrong. Forgive yourself and move on. And so my first suggestion, number one, is forgive yourself. Number two, inform and educate yourself. Ralph Waldo Emerson said, there is no knowledge that is not power. And I feel that many people fall into a trap where they feel like they have no control. They have no way of, in a sense, seizing ownership and direction of what is happening with them. And so I really encourage all of my patients, but particularly those who have gotten this new diagnosis of a cancer, to seek out sources of information and to become informed. And on here I've listed several potential sources, both locally. For example, the Abrams Cancer Center, their website, American Cancer Society, the American Lung Association, National Cancer Institutes. There are many others. It's not meant to say that these are the only ones, but just some examples. And in the handout that I gave you, I talk about questions that you should ask your physicians, particularly if the diagnosis is new. And you'll find those questions in the handout that I gave you. Again, these are questions that one could use about any kind of situation, any kind of medical condition that one would have. But again, it lists some of the things that I think are very much relevant to a cancer diagnosis, particularly a lung cancer diagnosis. So I'd encourage you to take a look at those questions. So we've said forgive yourself. We've said inform and educate yourself. Third, I would encourage you to assemble a network of support. Passage from the Bible. Though one may be overpowered, two can defend themselves. And a cord of 3 strands is not quickly broken. What do I mean by this? I'm talking about family and friends and loved ones. I'm talking about spiritual, religious, faith-based communities. I'm talking about your healthcare providers, social worker, or the patient advocate or navigators, and support groups. Again, I'm stressing this because there is the tendency to turn in, to become very closed, to isolate oneself. And again, in this journey that you're making, you cannot, must not, should not do it alone. And so I'm putting the onus on you. And that could involve, as I said, family and friends and loved ones, spiritual communities, engaging services through your healthcare providers, and then importantly, support groups. Number 4, reestablish and reaffirm your important relationships. Other things may change, but we start and end with family. Why is this important? First of all, it may help to provide closure to you personally. And again, in my experience, what I find is that as people begin to negotiate these issues, they begin to do life review, they begin to think about things that they wish they had done, wish they had said, missed opportunities. And so it's important to be able to do that, because I think it's, again, it's helpful as you make that journey. It's also helpful to family and loved ones. Now, in this regard, there is a wonderful book by a guy by the name of Ira Byock. It's called The 4 Things That Matter Most. And he is one of the leading figures in terms of cancer issues and end-of-life issues. And he titles the book, again, The 4 Things That Matter Most, a book about living. And the 4 things that he's talking about are the 4 things that essentially we need to say to our loved ones, to our friends, to those who are part of our important relationships. And the 4 things he says are, please forgive me, I forgive you, thank you, I love you. And so let me just read to you the beginning of his book, chapter 1. It says, saying the 4 things. He begins with, please forgive me, I forgive you, thank you, I love you. These 4 simple statements are powerful tools for improving your relationships and your life. He says, as a doctor caring for seriously ill patients for nearly 15 years of emergency medicine practice and more than 25 years in hospice and palliative care, I have taught hundreds of patients who were facing life's end when suffering can be profound to say the 4 things. But then he goes on to say, but the 4 things apply at any time. Comprising just 11 words, these 4 short sentences carry the core wisdom of what people who are dying have taught me about what matters most in life. And then he adds, ask a man who is being wheeled into transplant surgery or a woman facing chemotherapy for the 3rd time what's on his or her mind, and the answer will always involve the people they love. Always. The specter of death reveals our relationships to be our most precious possessions. I've lost count of the number of times I've met people in my office, an emergency room, or hospice program who have expressed deep regret over the things they wish they had said before a grandparent, parent, sibling, or friend died. They can't change what was, but without fail, their regrets have fueled a healthy resolve to say what needs to be said before it's too late, to clear away hurt feelings, to connect in profound ways with the people who mean the most to them. Reestablish, reaffirm your important relationships. Please forgive me. I forgive you. Thank you. I love you. Next thing is become comfortable with palliative care. Martin Luther King said, the quality, not the longevity of one's life, is what is important. Now, let me pause for a moment and ask, when I say palliative care, what comes to your mind? I'm going to look at Sister Quay. As you finish your dinner, when I say palliative care, what comes to your mind? Okay. So the kind of the emotional piece, the supportive piece. What else? My friend, when you hear palliative care or hospice care, what comes to your mind? near the end of one's life. Okay? Okay? Okay. I like your answers because you stayed away from something that I will often hear when this topic comes up. And in some people's mind, and I think, in fact, in many people's mind, when they hear palliative care or comfort care, it's as if we've given up. It's as if we are abandoning the patient. It's as if we are saying, bye-bye. And that is, in fact, the furthest thing from the truth. And so I like the answers you gave because they emphasize we're now focused on not cure anymore, but we're focused on enhancing and maximizing the quality and meaning and significance of whatever life you have. And that could be many years, that could be many months, that could be just a few days, could be even just a few hours. But the focus is not the sense that we have given up. It is never the sense that we have abandoned the patient. What we're saying now is that we are putting our full attention, our full concentration, our entire focus will now be on maximizing quality of life. And so, some thoughts here. Actually, my pointer does not work too well, but it focuses on the relief of pain, stress, and other debilitating symptoms of serious illness. So number one, it's on comfort, physical. The goal is to relieve suffering and to provide the best quality of life for patients and their families and their loved ones. So it's not just about the patient. It also includes the family gets brought into that process of quality of life care. And note, it can be provided at any time. So again, it's not necessarily about at the final hours. We're talking about a serious illness, a potential life-threatening illness, where we're beginning to look away from cure and begin to focus on maximizing the quality of life. And again, I want to stress this definition is important because we don't necessarily have to be in the terminal end phases. Okay? We can be talking about months or even years, and we're still focused on these issues. Hospice, we restrict the term hospice here to that period when not only we're focused on comfort, but we're beginning to anticipate death. But again, even if we are anticipating that, does that mean we have given up, or that we've abandoned, or that in a sense we are viewing the patient, and I hate this word, hopeless? My friends, I believe that there are always good things that we can hope for. There's always something that we can look forward to. Always something. And so hospice, again, is very much focused on, when life expectancy is measured on the order of months, when the focus is definitely not on cure. It accepts that death is a natural process. We don't need to fight it. And it is not designed to help someone die, but again, to live the remainder of their lives as fully as possible. And I'm harping on this because I hear this, oh, doctor, it means you're giving up. Okay, I say this, I never give up on anybody. I tell them that up front. You're giving up on me, doc. I said, no. I never give up on anybody. What I do is change the goal. I change the target. But I'm always striving and trying to do something good and positive for the patient. And so I would encourage you, as a suggestion, to become comfortable with this notion of palliative care. Take control of your future. What do I mean by that? Confucius said, a man who does not plan long ahead will find trouble at his door. And fundamentally, what I'm talking about is completing an advance directive, also known as a living will. And in your materials, I gave you a copy of an advance directive that I think is very much user-patient friendly. It's called patient-friendly, and it's called the 5 Wishes. This is not to say that this is the only document or the only approach that one can use. It's just presented to you as a suggestion. And the notion of completing the advance directive, it's about empowering you. And it is helpful to you and your loved ones. Now let me ask you this. Why would it be helpful to you to complete such a document? My friend, what do you think? Why would it be helpful to complete something like this? Or at least even think about it? Yes. Right. So, again, I've been doing this for 25 years. And I can't tell you how many times I've been in situations where on one level, the family knows what their loved one would want, but their what? Their fear, their grief, maybe their anger. Sometimes in their grief, I didn't want to go there, but sometimes, you know, I don't like to think ill of families, but there's no question that sometimes it can be. Okay. So the doctors have a general way of saying that. We call that secondary gain. Right. So there may be all kinds of, families may be conflicted in a variety of ways, potentially compromised in a variety of ways that prevents them from speaking accurately and appropriately on your behalf. And so having something like this can be helpful. And even when there is no, maliciousness, it can be sometimes very hard. And so having something like this that is clearly stated what your goals and values were, what your desires are, will be very helpful to them. Yes, please, go ahead. Right. So I want to be clear that I'm talking about a medical setting. I'm talking about filling out an advance directive that speaks to the medical issues. You can get a broader power of attorney that may speak to everything, but I'm focused on you indicating what your medical preferences are, what your desires are around your care. Okay, so that's an excellent point, that we're really referencing a medical situation, and the fact that someone is speaking in this setting doesn't necessarily mean that they are able to speak in others. Right. Sure. That's exactly right. Right, right. Would I be able to get a pointer? Do we have one? So, sister, that's why I kind of mentioned this piece here, that there needs to be a conversation that involves you and your physician, so you can you know what the medical issues are that may come up or that would be relevant to you, that you want to reflect in the document, and you want to be able to clear up any other ambiguities, and to make sure there's a conversation with the family, your loved ones, that you've identified a decision maker who is going to do what? Right. Who's not going to respond from their heart. And sometimes you may have, let's say 3 or 4 kids, and you know which one is the right one to really speak on your behalf. You know which one is going to be, can I say, maybe less emotional or more objective, who will be a little less passionate about the whole thing, and who could really act on your behalf. Now, the important thing about the advance directive is that it only operates when what? That's right. So this is key. This can never be pulled out and somehow, if you're competent to speak, this has no meaning. This doesn't exist, so to speak, until you lose that ability to speak for yourself. Then it becomes operational. Because sometimes some people will feel like, well, maybe they're going to pull. No. This only becomes into play when you can't speak for yourself. So make this a conversation, and once you have done this, don't hide it. Doug, I've been in situations where people, they go to the trouble, they get a lawyer. And it's a beautiful document. And where do they put it? They put it in a safe deposit box with all of their other valuables. And then when we need it, the patient is sick, on a ventilator, can't speak. We know there is a advance directive someplace, but we can't find it. Right. So absolutely, it needs to be distributed. If you've identified somebody to be your decision maker, they should have a copy. You should have your own copy, and you should give it to your health professionals, your healthcare providers, so that they can put it in your medical records. Again, that's one of the biggest problems I've seen, where the advance directive is filled out, they do the right thing, and then we can't find it, and so we're still back to square one. And now my final suggestion is leave something behind, give something back. Again, another quote from the Bible. It says, "The generous man will prosper," and I love this, "he who refreshes others will himself be refreshed." If you're at a point where you're looking to find some meaning in your life, this is something to do. Ultimately, you should identify what's the best way for you. It could mean getting involved in a research study. Now, I mention that because we're dealing with a group of African Americans, and one of the issues that we struggle with as investigators is that oftentimes African Americans decline to participate in clinical trials. You know some of the reasons for this, right? Right. So, without denying what has occurred in the past, we do no good for the future We do no good for the future if we let those historical things continue to control and affect us. Yes, bad things did happen. But I can say that real change has been made, and that the chances of abuse are much less, and the potential benefit significantly great, that I really encourage everybody, but particularly African Americans, to be involved in clinical research. Now, one of my colleagues here, Brenda, you do research, and I know you at times struggle with that issue of enrollment. I don't know if you have anything to comment on that. Okay. Mm-hmm. Right. Mm-hmm. Right. 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 Yeah. Right. Right. Well, I appreciate that willingness. In fact, virtually all of the funding agencies now require the investigators to explicitly consider the demographics of their patients, okay, and explain why, if they're unable to have a demographics in their population that reflects, you know, the local population. Doug. Sure. Right. Right. So, so that, in a sense, that would be a plus. But I would hope that, even, to be honest, so the financial remuneration tends to be relatively small. But I would hope, though, that for those of us who are at this point in our life, if we're looking for a way of contributing or giving back, that this is a meaningful way. You're leaving something behind. And again, I can't stress how valuable it is to get the appropriate kinds of participation, because we want the data to be accurate. And if it only has one particular group, then but by definition, it's not a complete study. Supporting research, giving to research, supporting funding research, or supporting fundraising. Sorry, so that's supporting fundraising. All right, let's cross it out. Supporting fundraising for research, participating in a support group, and I want to say counseling young people. Again, I don't know what this group is like, but if, for example, you were a smoker or there were lifestyle issues that contributed to your cancer or your health status, you may not be able to impact yourself, but certainly finding some young person in your sphere of influence, getting close to them, saying, young man, young woman, I love you, I care for you, I'm interested in you. Let me tell you what happened to me. Here's what I wish I didn't do. Here's my hope for you. So I think these are just some ways of being able to give back. And as it says, he who refreshes others will himself be refreshed. So I just gave you 7 suggestions. Forgive yourself, inform and educate yourself, assemble a network of support, reestablish, reaffirm your important relationships, become comfortable with palliative and hospice care, take control of your future, leave something behind, give something back. So, let me get your suggestions. I gave you 7. I did my work. I need some suggestions from you. What else would you add to what I've said? Yep. Absolutely. Mhm. Right. Yeah. So, um, let me say that in some ways, that's what I was getting at. Okay? Um, and since you kind of brought it out and made it more explicit, let me emphasize that. I would say that fundamentally, that issues of illness, vulnerability, loss, disability, all those things raise questions of purpose. Like, why am I here? Why is this happening to me? It raised questions of meaning and significance. Am I important? Do I really count? And it raises questions of destiny. What happens next? What does the future hold? Those are fundamentally spiritual questions, not religious. I'm talking about those are fundamentally spiritual questions. Questions of purpose, of meaning, of destiny. And so, as Brenda was saying, I think that you do yourself a disservice if, in a sense, you just simply ignore or dismiss those issues in your mind. And so, whatever your faith tradition is or your faith background is, that may be the place to start. You may not end there. You may find something new or something may evolve out of that. But I think fundamentally, part of going through this journey is kind of getting into some kind of faith, spiritual, religious community that in a sense, helps you engage these issues of meaning, of purpose, of destiny. So I agree with you 100%. That's something that's a very important piece of this. And you're right, you could potentially pull that out as a separate category. Yes, go ahead. Yeah. Yeah. Mhm. Right. 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 So, you know, I don't want, and I'm glad you bring this up because it, it, it speaks to the potential challenge. I mean, it's not easy. I mean, I put it all on one slide, but that in no way is meant to kind of underestimate the difficulty, the challenge of trying to, either restore or work through relationships that may have been dysfunctional for years. you know, that may deal with issues that go all the way back to childhood. And so you may need help. And that's why that network of support comes in, where you can get advice and counseling and strength that may potentially help guide you as you work to restore or reconnect or just kind of place in the right footing our relationships. But there's no question that at times that may be the biggest challenge, not just the physical, but just trying to manage all of the drama and the irritation and just sometimes the selfishness and the self-centeredness of others in those situations. So having said that, those things are still important, meaning that the idea is that in many ways, if I, the individual, focus on what I can control, even if the other person is not willing to be forgiving, I summon the strength to be forgiving. I know I've hurt someone. I summon the strength to reach out and say, I'm sorry, even though it is hard and I'm embarrassed. I love you. Hard thing for men to say. Hard thing for men to say. And there may be people who have been waiting a lifetime to hear that. And it's not good enough to say, they know I love them. It needs to be said. All right? Mm-hmm. Yep. 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 Right. Right. Yep. 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 Yeah. Right. 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 And so that's why I say I think in some ways the patient has to take control of that. You know what I mean? I mean, with the patient, we have to, right? We have to somehow empower the patient. I mean, those of us who are healthcare providers, those who are social workers and other professionals, we need, in a sense, help our patients through those situations, and it can be tough. Just last December, I was in the intensive care unit, and I was involved in a situation where it was a very challenging end-of-life scenario. I mean, Dad was dying, and the medical staff was trying to transition to comfort, and the family couldn't go there. And the reason why they couldn't go there was because brother one, brother two, and sister were kind of relitigating and refighting a lifetime worth of battles. And we just happened to be collateral damage. And it's tough. And I think they made their take care. Right. So anyway, sister, I agree with you that the family issues can be a real struggle, and if it's not done right, it can make that journey, whatever is left in the person's life, whether it's weeks, months, or even years, it can make it a really difficult thing. Yeah. 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 Right. Right. Oh. Oh, it's a shame. Yeah. I think over here. Hmm. Right. Absolutely. Right. So let me say that in putting this list together, I don't mean to say that there's not necessarily a ranking here. I mean, I kind of put them together. Right, right. And so what I would say is that however you choose to kind of organize it, I think that is good. And again, like I said, I would certainly not, both what you said about the relationship piece and the spirituality piece, they're critically important, absolutely. Doug? Right. 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 So what he's saying is, I think you're right. I could add to this advocacy. I mean, that may be another way in which you could get involved and give back. Particularly, if you've had a lung cancer that's been related to smoking. I mean, who better to speak to that? Particularly if, for example, you started young, and you kind of got sucked in, and you got seduced, so to speak, into that. So I agree with you 100%. Advocacy would be another area in which one could meaningfully contribute, particularly as someone who has the disease or had the disease. Praise God. Okay. Mhm. Right. Right. Hmm. Okay. Right. Right. And they're positive about it. Yeah. Right. 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 But I think though, but I think you're coming from a place of experience, which I think is very important. And so in some ways you're already doing what I'm suggesting here, that you're reaching out. And again, it's so let me say that as a lung doctor, I don't want anybody to smoke. But yet, when I deal with my patients, I always try to come from a place of not condemning, not judging, and in a sense saying, when you're ready to quit, I'm here. Okay? So I would never ever want, for example, a patient to say, well, I can't come to Dr. Delisser because he doesn't want me to smoke and I'm going to upset him. No, no. Come anyway. Tell me you're smoking. I'll tell you that I wish you weren't smoking, but still keep coming. You know what I mean? So I think you're absolutely correct. You have to have an approach where behind all of it is you're concerned for them. And I think that's ultimately what it has to be. Right, right. Yes, very much. Go ahead. Yeah. Mhm. Absolutely. Yeah. Right. 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 Well, good, good, good. So again, you're kind of, in a sense, re-emphasizing a lot of things I've said, and I really appreciate that. The last thing you said, again, getting that support network, assembling it. So some of it, you have to be intentional. I mean, you can't wait for others. So you get that support, and as you said, just kind of letting others know, then we can kind of rally to your side. That's really good. Yes, sir. Very good. Thank you for that. Thank you for that. Right. So, so I guess that's a nice transition into this question part now. So, what I can tell you about that is, compared to other cancers, we really do not have a well-validated screening test. Now, there is emerging evidence suggesting that CT scanning of the chest, CT scans of the chest, may be able to allow us to find lung cancers early enough to affect outcome. Right? What's happened to this point is that all the screening that we've used has allowed us to find cancer earlier, but patients don't live any longer. So it's as if we're just finding it earlier, and you're living with the diagnosis longer, but you're still dying. So that's been the challenge with lung cancer. And to be honest, there is no good screening right now. As I said, there is data that's emerging that suggests that maybe CT scanning, if done in a certain way, at certain intervals, may allow for us to pick it up early enough where we can affect outcome. Right. Well, so they actually, a number of studies have actually done that, meaning in patients who were high risk for lung cancer, meaning they were smokers, active smokers, and did frequent x-rays. And I think as frequently as, like, say, every 6 to 12 months. Okay? Doing it that way still does not change outcome, meaning you may find it earlier, but we don't find it early enough, and the x-ray doesn't allow us to distinguish the really aggressive lung cancers from the slower growing cancers. So that's what everybody thought. Let's do chest x-rays very frequently. And when they've done that, it just hasn't affected outcome. Right. Right. So what I would say is that, Becky, right? Okay. Okay. So what I would say is that all cancers, at the end of the day, are individual. And so even if you may have all of the risks, you may never come down with a lung cancer. Meaning somebody, let's say somebody who smoked, they were around asbestos, they were in a chemical factory, they had all the risks. they get nothing. Someone like yourself, let's say, no exposures, no smoking, no secondhand smoke. You eat properly, you live right, you come down with it. So at the end of the day, we're always talking about risks. We're never talking about anything that is absolute. And really what we're saying is that if you don't smoke, you decrease your risk, but it never eliminates the possibility that you could get the cancer, because all of us are individual and we may have our own genetic makeup that predisposes us or makes us susceptible to cancer, independent of any known risk factor. So what I would say is she's the exception. So I wouldn't necessarily think about her, and what I would do is, what can I control? So I don't smoke. Okay. And I would apply that to any kind of disease. So they say cardiovascular disease. So I know if I watch my diet, I know if I control my blood pressure, if I've got diabetes, I control my sugar. Okay. There are things that I can do, but we all know of instances of people who are perfectly healthy, vegetarians, exercise, perfectly healthy, and they come down with a heart attack or a stroke. And it just says that on an individual level, we can never, ever absolutely predict what is going to happen to you. Or what we can do is lessen the risk. Yes. Right. 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 Yeah. Well, I guess what I'm saying is, that, in a sense, our understanding of cancer is still in a very early stage, despite all the research. That is still more to learn and understand. So let me give you an example of something that has stuck with me throughout my career. I had a patient who, about 17 or 18, presented to us with what looked like a pneumonia. Wasn't getting better, so we decided to do a bronchoscopy where we went in and got some tissue just to figure out what was going on. We were thinking he had an unusual infection, and that's what we were looking for. To our utter surprise and just disbelief, this 17-year-old, 18-year-old had lung cancer. Okay? And it was at a very advanced stage. Okay. So there's nothing that this young man did in terms of a lifestyle that brought this on. So there was something inherited or genetic that predisposed him to this cancer. And so what I'm saying is that we are making progress, and we're beginning to understand some of those mechanisms and some of the inherited factors that predispose. And some of it can be racial. Some of it may be ethnically based. And some of it may just be you as the individual. Yeah, so it's certainly going to be a combination of both genes and environment. But in any given situation, one may be the more dominant factor than the other. Yeah. I mean, just to talk about risk again, and we'll wrap up. If I were to ask you what percentage of lung cancers are associated with smoking? Talk about cigarette smoking now. What percentage of lung cancers are associated with cigarette smoking? What number would you give me? How much? Higher. Higher. All right. So about 90% of lung cancers are smoking related. Now let me flip it. What percentage of smokers come down with a lung cancer? What percentage of smokers? I'm talking about people who smoke a significant amount. No. 10%. Yes, right. That is why, that's why, in fact, now, remember, you got millions of smokers. But this is why people continue to smoke, because the effects aren't immediate, and you may get lucky because you got the right set of genes and not get it. No, no. Right? All right. So now, I want to be quick to say that the thing about smoking, though, is that it not only increases your risk of cancer, lung cancer, increases your risk of things like mouth cancer, esophageal cancer, increases your risk of bladder cancer. It increases your risk for cardiovascular disease, strokes. So I'm just looking at lung cancer. So you may dodge the lung cancer bullet, but there are a couple other bullets in that chamber that could still get you. So, but I'm just making the point about understanding risk. Yeah. Well, let me just close with this.
Can I just touch on one thing about
Yeah.
palliative care? Remember when my father was in the hospital? This was about 11 years ago. He had an arrhythmic heartbeat, he had lymphoma, and he had the type 2 diabetes that he hadn't managed well at all. They took a couple of toes, and they took half a foot, and they took below the knee, then they took above the knee, then they wanted to do the same thing and working on the other leg. And, at some point, I think my father just lost his will to live. But I don't have brothers or sisters, so it was just me and my mother. And, I had to make, my mother was a wreck, so I had to make all the really tough medical decisions. So doctors pulled us in, and he was in ICU for a long time. And pulled us in and talked about death with dignity.
Sure. Right. Right.
It was just the doctor's opinion. I just said, they're just trying to, my father's been in the hospital for 6 months. They want the bed. I guess they want that, But, let's talk about that concept.
Right. I have to say that I think that that's an issue for African Americans, and that's why I'm actually glad that we're here today. I think in some ways our history makes us suspicious. And I think in some instances, there's reason to be cautious. Okay? But what I would say, though, is that I would want you to step back, think about your loved one first, okay? And not let your suspicion or distrust blind you from focusing on mom, dad, brother, sister, son, daughter. And thinking about what are they going through right now? How are they suffering? Are they suffering? Is it my grief that's driving this? Is it my anger, or is it my guilt? Okay. So, like I said, I think there's reason to be, I would say, cautious. I mean, I think there's reason to ask questions. There's reason to push the physician to make sure that they have done the best that they could. Okay. Well, and obviously you don't want to go overboard. But what I'm saying is, though, I'm, for example, I'm very comfortable with people questioning me. Okay. Right. Right. And so I would hope, though, if I'm showing you respect, then you show me respect. So I'm very much comfortable with the conversation, with the negotiation, with the discussion. I also think it's very important for me to be patient, because I've done this 1,000 times, but this is your first time. And so it's all new to you. It's all foreign to you. It makes no sense to you. I've done this for 25 years. This is your first experience. So I need to recognize that, so I need to be patient. But what I find at times is that either the suspicion or the distrust takes over and consumes. And I keep the attention on myself rather than, can I look at my mom, can I look at my father and ask, what is happening to them? Okay? Are they suffering? And can we reframe this in a way of, can we close this chapter but go to the next one? And I would say with your father, to me, the question would be, how can I build on his legacy? That, to me, would be the way to keep him alive. Right? But you follow what I'm saying? So that is my approach when I'm dealing with those situations. Okay, this is sad. This is tragic. I feel pain, certainly not as much as yours. And I can honestly, when I see patients dying, I feel something. Not as much as the family. I would never be presumptuous to say that. But I sense their loss. And so what can we do next that keeps this person alive? If I can't keep him alive with a ventilator, then what I can do is maybe do something with his legacy or her legacy. Right. Okay. Right.
But to your point, to the end point, eventually I did, see the bits.
Yeah.
Sense his anger.
Right.
And I just said, all right, start with
Right. Sure. Right. Right. So I think in some ways, though, we do have one advantage now, is that the law is very explicit about what the hierarchy is in terms of decision making. Well, no. What I'm saying, though, is that one of the things that I can use in those situations at the end of the day is, yes. Yes. In those situations, hold on. Sister, let me just. I wanted to close with this slide. It says, life is a song, sing it. Life is a game, play it. Life is a challenge, meet it. Life is a dream, realize it. Life is a sacrifice, offer it. Life is love, enjoy it. You see? Yeah, so I guess, there's no question that families are challenging. You know what, though? I don't want to overstate the challenge, meaning I'm going to say that each group, each racial group, each ethnic group, each class has their own particular challenge. And so while there may be unique features to the African American family, I don't want to give the sense that somehow they're more trouble than others.
No, the only reason why I keep bringing it up, because this is what session you're in. If
Yes.
it was in the Asian,
Right.
or whatever have you do. I mean, I don't work just with the African
Yeah,
American.
right.
But what I'm saying is that, again, your health team, when mom goes to the nurse or to the doctor and says, I'm the mother,
Right.
and the husband or the wife is saying, listen, it comes to me, here's the paperwork
Right.
saying that I'm
Right. And so,
and then the health team
Right.
breaks that and say, well, can't you remember that's the mom? I mean, how can you do this to the mom?
so I think, sorry, you're absolutely correct. So I think, though, here's where you need to have, I guess, physicians and nurses and your whole care team who kind of understand the African American dynamic. I mean, I don't want
Not
to
just
just.
African American, but we have to be.
Yes, right. But I'm saying in that situation, recognize what the law says, what is ethically appropriate, and basically, if it's husband, wife, the spousal relationship is first. Okay? And so that's where we begin the conversation. And you're correct that the team has to be consistent in adhering to that. That is, if the husband is the decision maker, then it has to funnel through the husband. And then the care team has to be very consistent but respectful with others to say, it goes through them. Let's get together and talk about it, and let's see what the rules are. But I have to work through that.
See that the point to that discussion that we just had was how important that a directive is put in place.
Yes.
That's key.
Yeah.
If that directive is in place, then you know what the wishes of the person was.
Right.
Because I was just in a situation like that where my first husband died, but we were divorced, so therefore I was not in control. The second wife then
Right.
was in control of exactly what happened to him. Now I would have not gone that way, but that was her choice. And I had to step back and realize that I was not in control of the situation, and whatever happened, I could do nothing.
And that is years and years and years ago. My first husband died from lung cancer, and I was no longer the wife then. But by law, his children were his next of kin, not his wife.
Right.
See, and that gets real deep.
It gets,
But I'm saying by law.
yeah, but see what happened, those children were my children.
Yeah.
See, they were my children,
Because
but
the wife
still,
is not a blood relative,
Right.
according to law.
Right.
Yeah.
So, I mean,
It gets
right.
real.
Right. So, I mean, I think at the end of the day, my sense is though that I think if you're patient, if you're respectful, and if you genuinely listen, 9 times out of 10, not always, 9 times out of 10, those situations can be managed. At least I find in my hands that if I'm respectful, if I'm patient, and if I make the effort to listen, 9 times out of 10, I'm able to manage and negotiate those situations. Establish the rules, but do it in a way in which everybody feels like, okay, I've been heard. I understand what the realities are. I will have my opportunity, and usually, like I said, usually that works. Not always, as you know. I mean, there'll be that 5 or 10% that, it's going to be a mess. It's going to be a difficult situation, regardless of who is involved.
Because I just found out by working in hospice, my concern is the patient.
Absolutely.
That's all. I don't get involved in this part.
Right.
It's ugly.
And much of what I try to do when I'm in the intensive care unit is to have everyone reflect back on the patient. I mean, I need to hear what your issues are, and I hear that. But I need you to help me focus on the loved one, and let's decide when is the right time to go in another direction. Do we need to push on? Part of that is waiting for you to catch up, because sometimes families aren't ready. And like I said, I'm willing to be patient. I can't be patient indefinitely, because that's not a decision. But if you need some time, and time may mean a few days, it may need a week. I mean, I'm okay with waiting. Now, part of my job then is to get my team to also wait, because I may be in a frame of mind, because I've done this long enough to know the value of patience. But when I've got like a 26-year-old intern, they don't have the maturity yet to be patient. And so my job is to help them. I mean, honestly help them, meaning because they're frustrated, and so I have to respect where they're coming from, because, right. And it's hard at times to do care, getting back to your father, when, from a professional standpoint, you know what you're doing is not going to make the patient better. You know that what you're doing, in fact, is promoting the patient's suffering. Okay? And it's hard when you're you've sacrificed to be a caregiver, and you feel like you're not giving care. So part of my job is to help the nurses and the young doctors process that, meaning, and just recognize that part of being a professional is sometimes rising above your anger and frustration and showing your care by continuing to do things that aren't benefiting the patient, but right now, that's what makes the most sense. Anyway, thank you very much. Thank you very much. Did I stay in line most of the time?